So without further ado, I'd like to introduce Jess and Tahnee. Jess is a clinical nurse specialist in a mixed paediatric emergency department in Warrnambool and is now completing her training as a nurse practitioner. Tahnee is an emergency consultant, also working in Warrnambool, with experience across paediatrics, retrieval and emergency medicine. Thanks, Jess and Tahnee.
Hi, and thank you for coming to our talk. So the wonderful Don't Forget the Bubbles team gave us the title Great Care Out There, which we've adjusted slightly to the Paediatric Emergency Medicine tool belt. So hopefully at the end of this talk, you'll feel like we've shared some team approaches and tools to build PEM capacity wherever you are. You won't only have a hammer and everything won't look like a nail. You'll have a few screwdrivers, wrenches, etc. So are you going on a rural rotation? Are you considering a sea or a tree change? Have you married a local? Are you taking a break to locum? Are you taking retrieval phone calls and wondering what resources the referring centre's calling you, what they have? This talk's for you. So now we've made you rural curious. Out there, it's all relative. So here's a map of our beautiful country showing all the countries within it. So we're here on beautiful Ghana country, and Jess and I work on Gunditjmara land here at Warrnambool, which is about 270 k's west of Melbourne, or about 600 k's east of here, at the end of the Great Ocean Road. If you've ever seen the 12 Apostles, we're pretty close to there. So that's the meta, and let's drop down a level. So here's Warrnambool, because I imagine not many people in this room have heard of it. We're a town of 35,000 people with an emergency department that services the wider region of 120,000 people, 2 hours west of Geelong here, and then you can see Melbourne is about 3 hours west of us over there. So that's the sort of geography of where we're speaking about. Then zooming in a bit closer again, here's the Warrnambool Base Hospital with its lovely Kermit green signage there. So slowly getting some revamps. If you follow this road out the front to the end, you'll meet the Southern Ocean.
Thank you. And then if you take a look out the back of the hospital, you'll find the old building, and that's our home. It's a mixed ED. The glorious sunshine here is masking 3 ramped ambulances. Last year we had more than 25,000 ED presentations, and roughly a third of those are paediatric. Our model of care includes a consultant on every shift except for overnight. We've got a really healthy smattering of postgrad crit care trained nurses. We've got an NP contingent which run a fast track model, and a very busy paediatric team, and a 10-bed peds ward. And if you hang a right out the hospital doors and keep walking, you'll hit the beach. Warrnambool and Port Fairy around the corner. They're really cool to the new YoPro surf movement, particularly as these days get longer and warmer. And the beach calls to us for other reasons in the winter, with the migration of the southern rights as they hit the whale nursery to calf. There's never a bad day for the beach in Warrnambool.
So we've spoken a lot at this conference about improving care for our patients and families, about Safety 1 and Safety 2. We're lucky to have both moved to a centre that has really pretty good Safety 1 sort of level care. We've got wonderful paediatricians and some long-term emergency consultants before I moved there. So that's sort of where we were starting from. Every emergency department in a regional or rural area is rural in its own way, much like Tolstoy's Unhappy Families. So starting from where you're at, taking stock of your equipment and resources, and then focusing on one project at a time is really what we've found to be the most useful. And so today we're going to walk you through 8 projects we've done as sort of 8 little steps on the ladder to the sort of optimal care that Ben's just been highlighting in that powerful session for us this morning. So our journey.
So Tahnee started at Southwest Healthcare in 2019, and I started in the ED in 2022. We'd both met working at RCH ED together. It's been so nice to see so many familiar faces today as well. We also met our pal Sid Sunwoo, who is currently a PEM consultant at Werribee. He's been a really good sounding board for some of this mixed ED quality improvement projects as we've progressed through. We tried to lure him to join us today, but very happily he's recently welcomed a new baby to his family, so he's with us in spirit.
So I'm sure everyone in this room knows about the Predict Paediatric Research Emergency Department's international collaborative. So the first thing that Jess and I bonded over together after I'd been in Warrnambool for a couple of years, and then happily Jess started working in the Warrnambool ED, having worked together at the Royal Children's previously, was making ourselves a Predict research site. So we participated in the Kids Are Not OK, which I'm sure other people in this room did data collection for as well. So we just went through and did a lot of work together on the retrospective data collection. This gave us a shared project to connect over with a concrete goal and endpoint. And as essential in healthcare, it also provided a small amount of financial remuneration. So everyone takes you a bit more seriously when you have a bit of cash to splash. So the data collection paid us $8,000, which meant we had money to go shopping. So the first thing we talked together about, as a disclaimer, we received no financial remuneration from any of the products that we discuss in this talk today. But so the first thing we did was we brainstormed together with a plan, do, study, act model about what we felt might improve care in our department. In a regional centre with no play therapists, in a mixed setting that's not necessarily as family friendly as it could be, virtual reality really has a really powerful impact for the kids we see for their IV cannulas and painful procedures. So we were the first regional centre in Australia to get a smiley scope, which we've absolutely loved having, and we've been doing an audit of that that's ongoing, and we have it on a subscription model at the moment. Having a fun toy also was a great recruitment tool to other people to get them on board with what we're doing. So sort of having something a bit shiny and fun was a really great way to highlight what we were doing.
We do love shiny things.
Yeah. And bubbles.
Yeah. So prior to 2022, PEDS cannulas were prepared in our department by kind of running around the department and pilfering supplies from a number of different locations. This trolley was actually started by one of the consultants, but our working group has been able to stock it with fit-for-purpose supplies, and that's included infection control approved distraction boards, resources such as blood culture and maximum draw guidelines, and a checklist to keep it stocked. Some of the areas that we identified early on for improvement were staff's lack of awareness of the power of distraction for the paediatric population, and misconceptions about the application of EMLA and how long it can stay on for. There was also, we addressed the pressure injury prevention in our neonatal or infant cannulas as well. So this is just a picture of our final products. It's really simple, but it's been really effective for our department. So there's been significant improvements in the way we cannulate our paediatric patients, but there have been some hiccups along the way. We've sadly lost 3 buzzy bees, which I hear is not an isolated issue. So if anyone has any hot tips on how to keep a buzzy bee in your department, please let us know. And the trolley does need ongoing education and input from the working group, just to make sure nothing wild and wonderful has found its way in there or found its way out of there. This is kind of pertinent after that last speaker as well. We talk a lot in our working group about high risk and low frequency events, and thankfully in our community the death of a child is a low frequency event. But sadly there was a child that passed away in the community in the recent years, and they ended up in our department. We had to scour the hospital to find some equipment to make memento with this family. It added a level of stress to an already stressful situation. So this was a really simple implementation to ensure that this didn't happen again. And there's some links in there to our local policy and procedure about the coroners. The resus trolley was our next update. This was a pretty low-hanging fruit in some regards. Pipe have an awesome shadow board online, and we've just taken that and adapted that to suit our department. Securing a paediatric airway can be a really stressful situation for some of the people in our department, all of us really. So we just wanted to kind of offload some of that cognitive load. We completed an overhaul of a pretty significantly overstocked trolley, and because it was so overstocked, it was terrifying, especially all of the adult trained nurses. People were reluctant to go and take a look in it and learn about the equipment. And yeah, it just resulted in people avoiding it completely. We refined the checklist and removed an entire tub of equipment, including, I'm not even kidding when I tell you there were at least like 37 pieces of Comfeel or Duoderm in there. Decluttering made it much less daunting trolley that people felt more comfortable to check in about. And we've recently linked in with theatre to share some stock, which has recently included the introduction of laryngoscope blades.
Yeah, video laryngoscopes.
Yeah, thank you.
Yeah, small size for our video laryngoscopes. So moving on to some other resuscitation equipment. So the fifth intervention is when I first came down to Warrnambool, we didn't have a gas machine in the department. The gas machine was around in pathology, which obviously for all of our patients, but especially kids where it might have been hard to get a sample or that blood is really precious, we were having to lose a staff member to walk the gas around 100, 150 metres away, to then wait and get the printed receipt of the gas result and then walk it back around, which was delays for resuscitation, loss of staff, much like we were talking about the preparation of IV medications the other day and the oral switch. This was such an easy switch for us to put a gas machine in the department and really save our staff and keep it as a time-critical part of our resuscitation. Unfortunately, when I took this photo, it was when it was newly installed. So happily, the gas machine is now in use and being used obviously multiple times a day, but this was, the slides had to be uploaded a few weeks ago when it had just been installed and it just snuck into the presentation. Number 6 is our ventilator replacement. So as you can see, we've until very recently had the classic iconic Oxylog 3000, which is a workhorse for a reason. You can drop it from 75 centimetres and it will not break, but it's not ideal for anyone under 40 kilos. It's very poor for sort of breath sensing and kids we want to keep not paralysed or a bit lighter on sedation. It's really not useful for. You also can't drop the FiO2 less than 40%, so there's a few things there that we wanted to improve on. So when replacing equipment, we've always tried to make sure we consider our paediatric patients as well as our adult patients. So the first ventilator that was suggested that we purchased by the hospital was an adult-only ventilator, and we just really highlighted the need to have a multi-capacity ventilator that is also, the Hamilton T1 is used by retrieval by Piper in Victoria. So this ventilator means that when we intubate and ventilate kids, they're on the ventilator they're going to be transported on. And it saves the retrieval doctor time when they get there. They're not then trying to switch to a different ventilator and then, sort of give them 20 minutes, half an hour, adjust the settings, see what we need to do here, what's our peak. They can just know that when we're calling them, that it's much easier frame of reference and it saves time for that lengthy retrieval as well. So we happily have 2 of those now.
Thanks. We've also had a real push for education and department engagement. As you guys may know, September is Sepsis Awareness Month, and sepsis criteria in an adult population is pretty cut and dry. I think particularly nurses feel really confident having that to fall back on. But we know that identifying sepsis in a paediatric patient is a little bit more complicated than a set of vital signs in the peach on the Victor chart. So our working group has linked in with the Sepsis CNS group and developed a weekly sepsis poster throughout Sepsis Month. We discussed the various areas that we felt that we could improve in and developed 4 different posters in line with the Safer Care Victoria and the PIC guidelines, and finished with a poster debunking fever in kids' myths. In particular, we recognised that there was room for improvement in the collective understanding of the approach to a febrile neonate in our department, and developed a poster around that. And we're really looking forward to October, which is PEDS Education Month. So all of the nursing staff in particular will be given a heap of education around capillary blood gas sampling, the updated PIC asthma guidelines, rashes in kids and things like that. These are some of the posters that we've created. Really simple and bright and eye-catching. And I guess if you're working somewhere regional and you want to touch base, maybe we can share resources or something like that.
So number 8. So Jess and I have been doing a lot of work together, but we're only 2 people. So in June of this year, we've really tried to expand our numbers. Happily, I think we've made it a really appealing option for a lot of people in our department. So we've immediately gone from 2 to 8 in our paediatric emergency medicine working group. So increasing ownership and building resilience in our department to try and reach all aspects of the team. So happily, we now include Raya, Tahnee, Paige, Jackie, Megan and Rhiannon. So this includes inpatient paediatric registrar, additional nurses, nurse educators, paramedics, permanent night shift staff, and a really great skill mix to make sure. I think one of the things we highlighted in our discussions was about reaching night staff, who they might be nurses or doctors on permanent nights, who might not be reaching education or getting the updates that the day staff are getting. So trying to make sure our team's reaching them and that that's a high risk time for our patients. So working out ways to do that. So in summary, here's our toolkit that we've been working on in Warrnambool. So kind of summarised as staff, space, stuff, and it's really all about the people. But so our PEM team, with an ongoing connection and presence to the unit, being there permanently, not locums or transient. Wider networking within the hospital and external collaborations. So for example, we've got a wonderful paediatric inpatient team that we collaborate with very closely, as well as Predict, Piper for retrieval, and other regional and mixed centres. The IV trolley, including the buzzy bees, dressings, distraction boards, the use of distraction in general for procedures that we've really had a marked uptake in, education and engagement, so the learning and culture in our department, including through especially themed months, the resuscitation trolley update and shadow board, the consideration of kids with other resuscitation equipment, like the ventilators and the gas machine, and enhancing the space and redevelopment going forward. So we're in a bit of an old space at the moment. We're looking to get an Indigenous mural put into our current space to make it more engaging and culturally safe for everyone to access care, and then looking forward to our new department as well, where we're looking through different models of care and ways to design the space to optimise care for families. So hopefully towards the end of that you feel like you've got a few more tools in your tool belt, and goes through what we've managed to do in our centre. Given we have a little bit more time, just going to the future, so from where to from here? We're going to continue to build our team and create resilience. We want to have more research involvement, which we're signed up for further projects with Predict, as well as other local projects. Ongoing education, especially simulation and neonatal resuscitation, are two things we're doing more of going forward, so additional simulation supplies and links with Deakin University. Redeveloping the space with the future new department, and ensuring there's a safe and respectful culture so all feel welcome and can access the care they need. So a little bit more about Warrnambool, since it's don't forget the bubbles and context is everything. So when I said I was doing this talk to some of my colleagues, they said that I should highlight that we're in an agricultural area, and farm kids and risk and different tolerance for risk was thought to be a good topic to discuss. Other people thought I should highlight that the motocross with kids as young as 7 with motorbike licences is 5 minutes down the road. But I thought I'd highlight this 9-metre slide that our council put up last year. As you can see, it's pretty steep, it's pretty fast. There's a person just over here for reference to the height of this slide. They've put in one of our largest playgrounds around the lake and the ocean. So we saw quite a lot of injuries off this slide. As you can see, that it ends in quite an abrupt finish here onto quite a hard surface. So we highlighted this to the council, who put up a sign highlighting that it was a super fast, super fun slide. One person at a time. Don't go down head first. If you're under 12, check with your parents. Older kids and adults, know your limitations. A lot of adult injuries also off this slide. Don't use it when it's wet, and don't use it at night time. But the slide is still there and open, so if anyone's visiting us, you might like to have a family policy about whether you're going to use the slide or not as one of our key attractions. Now that I've publicly slandered our local council and their decision making, I just also wanted to highlight that we've got a beautiful new library that the council also built, so they also do good things, which won a bunch of architectural awards last year. Here are my kids on the left enjoying the library that's in the centre of town. So we used a lot of resources, and we continue to do so with our work. So Southwest Healthcare Warrnambool is the official name of the hospital. The Predict Research Collaborative continues to be a wonderful source of support and inspiration. Many resources around distraction therapy, and we're looking forward to Beth's talk up next about distraction and how we can best care for our kids. The RCH and PIC guidelines are used extensively, and Safer Care Victoria now has Safer Care for Kids coming out, which we continue to use for education as well as some other guidelines that I'm happy to talk more about with anyone else in a similar situation. And
finally, this is like our unsung member of staff on our working group. This is my dog Elka, and she's made it to quite a few of our meetings.
yeah,
This is her enjoying the Hopkins River mouth. So when you come to locum, etc., you'll have to check out the Hopkins River mouth. Thank you.
yeah, thank you very much.
Jess, Tahnee, thank you. I don't know whether I want to go and work there more for the river or for the slide, to be honest. Did we have any questions from the audience?
Is the slide near the pub?
Yes,
Everything's near a pub in Warrnambool.
there's a lot of pubs.
Hi, I'm Laura. I'm a Gen Ped in rural New South Wales. I want to copy everything you're doing. Can I get your contact details?
Absolutely.
Thank you.
I can chat to you after if you like. Yeah. Easy to spot you in the rainbow top, so that'll be good.
Thanks for that. Equally, yeah, if there are jobs going, let us know. As a FACEM, I guess you've got FTE to do this work, but I was curious to know if you also did get some FTE and paid time to do this extra awesome work that you're doing.
It's an excellent question, and it's a work in progress.
Good luck.
Continue to advocate for.
Yeah. I think it's coming.
Yeah, I think that we are getting it for our nurses. We're advocating very strongly for the other people in the working group as well. Now that we're up to 8,
Yeah.
we're doing a 2-monthly meeting, and I feel really strongly that everyone should get paid to come to that meeting, and also that everyone should be paid for their involvement, because without staff we're nothing. So we're really advocating strongly for it.
Might have time for one more question if there was. Awesome.